evening to say a few words. Kindly, sir, enlighten us with your few words of knowledge.
Good evening, all. A warm welcome to RSAP Academic Webinar Series, which is being hosted by RSAP Punjab today uh, on critical care. And I'm very sure that it will be a very good learning experience for all the delegates who are logging in through Zoom and on YouTube. I also extend warm greetings on behalf of RSAP Punjab for the forthcoming annual National Conference of Research Society of Anesthesiology Clinical Pharmacology, which is going to be held in AIMS Batinda, Punjab from 28th to 30th March, with post-conference workshops on 30th March, which are dedicated workshops intentionally kept on Sunday so that you can all learn from the experience. I congratulate Dr. Tanveer Singh, the National Governing Council member, and his team for organizing this webinar. And I also thank all the speakers and chairpersons for consenting to participate in today's webinar. Thank you very much.
Now, over to the first speaker. Thank you so much, sir. Thank you for your enlightening words. I encourage all to kindly come to RSACPCon as sir has already requested and help us grow the light of knowledge beyond any borders of. Okay, so over to the first speaker. Professor Dr. Gunjan Paul, Madam, who is the faculty in critical care medicine at Dayanand Medical College, Ludhiana, who will be speaking with us on the topic of steroids in ICU. Thank you, ma'am. Welcome. We welcome you all. The session will be chaired by Dr. Vivek Gupta and Dr. Sumit Kumar Jingan, sir. Both are well-renowned faculty. Dr. Vivek is a consultant cardiac anesthesia in Hero DMC, Ludhiana, and Dr. Sumit Singan is a senior intensivist at Columbia Asia Hospital, Patiala, Punjab. We welcome you all, sir, and extend a warm thanks for coming and joining us today. Thank you. Over to the speaker.
Good evening, everybody. Thank you for inviting me to this forum, and special thanks to Dr. Tanveer. I bring greetings from Dayanand Medical College Critical Care Department. Today, we will be talking about a very important but a controversial topic, that is steroids used in critical care. Steroids are used in various situations. Some they are indicated and others they are not. The enthusiasm of using steroids in critical care has been waxing and waning because conclusive evidence of their use is frequently lacking. Today, we will be discussing their role in various situations, especially the controversial ones, in relevance to the recent literature available, evidence available in literature that favors or discourages their use. So a quick recap that the first therapeutic use of steroids was more than 3/4 of a century ago for the treatment of rheumatoid arthritis. Recognizing that they have potential benefits as an anti-inflammatory and immunosuppressant, their use was explored across a spectrum of clinical scenarios like sepsis, ARDS, trauma, immunological diseases. And steroids, we know they are potent hormones which have diverse physiological effects that can have significant impact on the critically ill patient, both positive and negative. So the use must be very judicious, and that is why we are here today to discuss them. In health, it is the corticotropin releasing hormone from the paraventricular nucleus of the hypothalamus that stimulates the release of ACTH in a diurnal fashion from the anterior pituitary to stimulate the release of steroids from the adrenal cortex. And these steroid hormones then have a negative feedback on the hypothalamic pituitary axis. And in stress, their secretion increases multifold. And how these steroid hormones act, they have an potent anti-inflammatory action by their genomic method. That is, they inhibit the nuclear factor kappa B that controls the, downregulates the transcription proteins, which is responsible for the secretion of the pro-inflammatory cytokines. So there is downregulatory action of these transcriptive proteins stimulated by the steroids, and these inflammatory markers decrease. So that this is a genomic action which takes time to occur. While at higher doses, there is a rapid onset non-genomic action because of the binding of the steroid hormones to the cytosolic glucocorticoid receptors. That is the effect on the cardiovascular tone. That is the effect on the skeletal and smooth muscle function. We have a variety of steroids available to us for clinical practice. The most they have different glucocorticoid and mineralocorticoid potency. Prednisolone, dexamethasone, methylprednisolone, they are agents which have a very high potent glucocorticoid potency. So they are used in severe inflammation. While we know fluorocortisone has high mineralocorticoid activity. And hydrocortisone is more preferred as a replacement therapy because it has short duration of action and it allows the hypothalamic pituitary axis to recover in between doses. So this is a very good article. I will encourage the participants to go through this. Steroid use in critical care, published in British Journal of Anesthesia in 2018, which enlists all the uses like in cardiovascular, in respiratory system, endocrine, neurological, immunomodulatory, and conduration and other situations. Before we proceed further, I will just want to re-emphasize that steroid use is a double-edged sword. Some clinicians use it as a last resort. If nothing is working, let us give steroids. But their use is not benign. It is associated with some serious metabolic disturbances like hyperglycemia, hypernatremia, immunosuppression, even upper GI bleed. And these all things may be linked to the poor outcome of the patient in the ICU. So coming to the first clinical condition, that is critical illness-related corticosteroid insufficiency or CIRCA. We know that increase in plasma cortisol concentration is a part of the adaptive response to stress, and inappropriately low levels are linked to increased mortality. So this term of or concept of critical illness-related corticosteroid insufficiency was coined in 2008, and in 2017, the European guidelines came for the diagnosis and management of this condition. But further research, we realized that cortisol levels are increased, but they are much higher than the rate of increase of cortisol production, and the ACTH levels are decreased. If it is by the stimulation of the hypothalamic pituitary axis, the ACTH levels should also be increased, but they are contrastingly decreased. So further research resulted in that there is glucocorticoid dysregulation in sepsis and stress, and 3 pathophysiological theories have been put forward. Despite the normal neural stimulation, in sepsis, there is something new, humoral stimulation also. That is the inflammatory markers, the PAMP and the DAMP proteins cross through the blood-brain barrier, stimulate the hypothalamus or directly stimulate the adrenal cortex to increase the level of glucocorticoid stimulation. Normally, 75% of it is bound to cortisol binding globulin and it is metabolized in the liver and in the kidney. But in sepsis, these enzymes are decreased, the cortisol binding globulin is decreased, increasing the level of free glucocorticoids. These cross the plasma membrane and they bind to the glucocorticoid receptor, which in combination crosses the nuclear membrane to show its genomic effects as anti-inflammatory markers. But there is dysregulation, there is glucocorticoid resistance as well. So these all mechanisms, that is the dysregulation of the hypothalamic pituitary axis, altered cortisol metabolism and glucocorticoid resistance, along with the loss of diurnal variation, leads to the increase in levels of cortisol. So to understand it better, we can divide our patients, which we see in the ICU, into 3 categories. There may be a category of patients with pre-existing intrinsic hypothalamic pituitary axis disease, but it is clinically latent. And when precipitated by some stress like trauma, burns, or a post-operative stress, these patients might present an adrenal crisis. Here, by the level of ACTH and cortisol, we might be able to differentiate whether it is primary or secondary deficiency, and steroids need to be supplemented. The second category is the most common category of patients which we see, acute sepsis patient coming in shock to the intensive care unit, not responding to fluids and vasopressors, refractory shock where steroids are indicated. But as I just outlined, that it is not the failure of the maximally stimulated adrenal cortex. We do not need to do a ACTH test. The ACTH is flawed here because this neural mechanism is active. It is the failure of the peripheral mechanisms, and there is substantial increase in the cortisol distribution volume. Merely indicates that the severity of the disease is high. Here, when we supplement steroids, there is pharmacological effect and the blood pressure might show a response, but it does not mean that endogenous glucocorticoids are deficient. The third category of patients, actually prolonged a critical illness in the ICU requiring mechanical support and other vital organ support, may show signs of critical illness related cortisol insufficiency. They may have, these patients are the one which will have decrease in the free cortisol levels and ACTH. They may be encephalopathic, delirium. Even if stopped the sedation, the patient is not waking up. There is continued need of organs support, especially vasopressors. There might be electrolyte disturbances. So see, these are the possible signs and symptoms. And this is precipitated because there might be slight exogenous cortisol glucocorticoid supplementation, also because there are high circulating bile acids, opioids, these and endogenous glucocorticoid receptor ligands, which continuously stimulate the hypothalamic pituitary axis. There is sustained negative feedback inhibition and decrease in the ACTH mediated secretion of glucocorticoids. And these phenotypes may be precipitated by use of other drugs in the patients because of the prolonged stay, like opioids, etomidate, azole derivatives, rifampicin, and phenytoin. So here, these patients classify into the category of critical illness related corticosteroid insufficiency, and a small dose of supplementation of steroids may help to may be pharmacologically effective. That is 60 milligrams daily or 40 in the morning and 20 evening to simulate the diurnal variation. So till now we have come to know that inability to maintain high steroid levels in acute illness is associated with mortality, and the ACTH stimulation test is not appropriate to diagnose Sarkai. But what is still the topic for further research that we don't know, that what are the risk factors for Sarkai in patients who will develop these conditions? What are the clear clinical diagnostic criteria to diagnose them? And what is the threshold level of free plasma cortisol has not been established. Coming to the second topic, that is septic shock. The journey of steroids in septic shock has been long. In last 2 decades, there have been variety of many studies thinking that there is relative deficiency of steroids in sepsis. They have been desperately tried by many researchers, but the evidence, what is the conclusion of all these studies is that all steroid supplementation in septic shock results in faster resolution of shock, but no mortality benefit is there. Similarly, there have been, of all these trials, there have been recently published many meta-analysis of more than thousands of patients, all showing that higher rate of shock reversal as compared to placebo, with no reduction in the risk of death, possible reduction in the length of stay, and only slight increase in hyperglycemia, hypernatremia, and neuromuscular weakness. So why it is that we are not able to show in the meta-analysis what we sometimes see clinically? Because the heterogeneity in the sepsis itself. The RCTs which are included in these meta-analysis, even in the control groups, the mortality varies from 6% to 93%. So heterogeneity lies at the individual level, at the disease sepsis itself. So clubbing these patients in randomized controlled trials will not give us the result which we want to see. So some trials, they're inconsistent in their mortality data. Some trials show that steroids are evil, others saying they are fantastic, but they are consistent in their secondary outcomes, and the undesirable effects are anticipated to be small. So because of these reasons, the surviving sepsis guidelines from 2016 till 2021 and 24 have been recommending the use of steroids only when fluid resuscitation and vasopressor therapy does not restore hemodynamic stability. The dose is hydrocortisone 200 milligrams in divided doses as continuous infusion. ACTH Kindly mute yourself, please. The ACTH stimulation test is not recommended. Neither should steroids be given when the patient is able to maintain the hemodynamics with fluid resuscitation or vasopressors, and steroids should be tapered when vasopressor doses are no longer required. The update of these guidelines in 2024 was again published, and that also recommends emphasizes the same thing. In the other cardiovascular indications, the perioperative use of steroids, if the patient is on chronic use, that is more than 10 milligram prednisolone daily for more than 3 months or equivalent dose, for minor procedures, hydrocortisone supplementation 25 or 50 up to 50 milligrams on induction is recommended. For major surgeries, higher dose may be recommended and needs to be followed up 48 to 72 hours post-surgery. And the perioperative team should plan an individualized plan for the patient. But however, if there is unexplained perioperative hypotension in such patients, do think of steroid replacement. Second, another indication is anaphylaxis. We know steroids are the cornerstone of treatment along with adrenaline and IV fluid administration, a dose of hydrocortisone of 200 milligrams IV. Like sepsis, another controversial topic is role of steroids in ARDS. Because of their ability to inhibit the progression of ARDS via the anti-inflammatory response, it is also very debatable. The ARDS network study showed that patients who come in late phase of ARDS, that is after 2 weeks on mechanical ventilator, use of steroids is associated with increased mortality. But what about early use of steroids? The 2017 European Society guidelines did recommend the use of steroids early in patients who present with moderate to severe ARDS. That is when the PF ratio is less than 200 and the patient presents within 14 days, methylprednisolone to be given in doses of 1 milligram per kg up to 2 milligram per kg. Why methylprednisolone was suggested? Because it has greater penetration into the lung, longer residence time, and as I told, it has more of glucocorticoid activity, less mineralocorticoid activity, less salt and water retention. So maybe the pulmonary fluid overload and pulmonary vascular resistance will increase less, which is good for the right ventricular in patients of ARDS. But they do emphasize that when we give high dose of steroids, infection surveillance is to be increase and should be prompt identification of infections and hospital-acquired infections. So there have been multiple trials and on the use of steroids, and COVID rekindled the use of steroids in ARDS, and in comparison, the network analysis was published in which all the doses of steroids were compared. That is low dose methylprednisolone 1 milligram per kg per day with 2 milligram per kg per day with hydrocortisone and dexamethasone. And low dose methylprednisolone was most beneficial in decreasing mortality, in decreasing the risk of infections, and also ventilator free days. So it is recommended to use low dose steroids for adult patients with ARDS. But again, I would like to bring to your notice this meta-analysis just to show that studies which favor the use of steroids are older ones, 2005, 2015, 2013. And as we understand the disease better, we are using lung protective ventilation, fluid balance, prone positioning. The later studies done in 2020, 2016 have come, the diamond is towards the neutral side. So it is not the steroids, it are other things which may benefit the patient in case of ARDS. So in summary, we can say corticosteroids probably are effective to reduce the risk of death in ARDS, also reduce the length of hospital stay and mechanical ventilation. And this has been seen across studies in all adult patients, COVID, non-COVID, all steroid types. And the effect on the harmful adverse effects of steroids remains unclear in this situation. So the balance of favorable and unfavorable effects probably favors the use of steroids in ARDS. However, which drug, what dose, what agent still remains to be, still is uncertain. However, the 2024 focused update suggests the use of steroids in ARDS only in hospitalized patients, severe ARDS, PF ratio less than 200. The third controversy is use of steroids in severe community-acquired pneumonia. There are contrasting guidelines. The American Thoracic Society or IDSA strongly recommends not routinely use steroids in both non-severe as well as severe CAP, while the European Society suggests steroids to be used. So it creates a dilemma for the clinician. So if we look closely into these studies, these all studies are small studies. There are more meta-analysis published than primary studies. All these studies have less than 600 patients. The Cochrane review showed that in severe CAP, there was a risk reduction of mortality by 0.58 as compared to non-severe CAP, but it is the poorly conducted studies which have skewed these results. These studies which have favored this, actually, if you look closely, they are not more than 80 to 100 patients. And although, see, the control group has increased patients with increased AKI. So obviously, there'll be more mortality in the control group and steroids will be beneficial. Similarly, another study included in these meta-analysis, 80 patients again, they have seen mortality only at 8th day, not even at end of hospital stay or ICU stay. And the patients requiring mechanical ventilation were already very sick, more number of patients in the control group and less in the steroid group. So such studies have skewed the results. So there was a need for a larger study, and this was published in NEJM in 2023, the Cape Cod trial. Double-blind, placebo-controlled, multicentric RCT of 1,100 patients, 31 French countries, and they significantly showed that hydrocortisone, the mortality was 6.2% as compared to placebo of 12%. So these results were very significant. And in summary, I can say that positive clinically important results associated with steroids include reduced duration of antibiotic therapy, reduced length of stay, and faster normalization of temperature and clinical stability. It is the small subset of patients only with severe CAP, which has been defined variably in different studies, but it should be severe enough to require ICU care. Similar to ARDS, the etiology of pneumonia is globally very varied, and it is uncertain that the disease might respond in a consistent fashion, making the effect of steroids difficult to elucidate. However, again, the focused update recommends the use of steroids, methylprednisolone, in patients who are hospitalized with severe bacterial community-acquired pneumonia, but they are not able to make any recommendation for less severe community-acquired pneumonia. Coming to another respiratory disease, that is obstructive airway disease, we know the use of steroids reduces the airway inflammation and mucus plugging that complicates bronchospasm. So use is recommended early in the course of acute exacerbations when there is incomplete response to beta agonists. Oral administration is equivalent in efficacy to IV administration as it speeds the resolution of airway obstruction and prevents late phase response. So oral prednisolone 40 to 50 milligrams per day or hydrocortisone 100 milligrams IV 6 hourly, and the doses may not be tapered if it is less than 2 weeks. Coming to another respiratory condition, that is PCP pneumonia. In HIV patients, the corticosteroid adjunctive therapy is confirmed and quantified the benefit. There is relative risk reduction of mortality. This is called corticosteroid adjunctive therapy should be given as early as possible within 72 hours of beginning of therapy. Prednisolone 40 milligrams orally BD for 5 days and slowly tapering over 3 weeks. Or if intravenous is to be given, 75% of the equivalent doses of methylprednisolone can be given. But they should be given only in patients of HIV presenting with pneumocystis pneumonia when they have hypoxia, because it was shown that there is increased mortality if we give it to unselected non-HIV patients. In selective patients without hypoxia, it increases mortality, but in patients with hypoxia, it should be started early. And airway edema, I think the anesthetists in the group are more well versed with this condition than the intensivists. We use steroids for the prevention of post-extubation stridor and for the fear of reintubation in patients of prolonged intubation. The American Thoracic Society recommends prednisolone 40 milligrams 40 milligrams at least 4 hours before in patients who have failed cuff leak test. And various studies show that dexamethasone and methylprednisolone are superior to hydrocortisone in preventing this. Our clinical practice is more of using dexamethasone, 4 milligrams per kg, 4 milligrams in 3 divided doses at about 48 hours before we plan extubation for patients where we fear stridor. Shifting gears and coming to the other organ systems, that is the neurological indications. Steroids are indicated in bacterial meningitis because it has very high mortality in both in children and adults. And even the survivors have significant neurological damage. So the role of steroids in bacterial meningitis was established after the landmark trial, which was a randomized placebo-controlled double-blind trial published in NEJM in 2002. It is because steroids decrease mortality associated with streptococcus and also neurological complications in patients with H. influenza meningitis. But a very interesting finding that was published in the Cochrane review was that corticosteroids reduced hearing loss and short-term neurological sequelae in high-income countries and not in low-income countries. It is because steroids benefit by decreasing the inflammation which occurs when antibiotic causes bacterial lysis. There is bacterial lysis which causes the inflammation and responsible for neurological damage. And if we give if we give steroids, so we have to give steroids with antibiotics or before. But the problem is that when you give steroids, the inflammation decreases and the passage of antibiotic to the inflamed meninges will decrease. So they are recommended to be given at the time or earlier. So because patients, the reasoning is that because the patients in low-income countries report sometimes late, so the benefit of steroids was not seen in these as compared to high-income countries. So the recommendation or benefit of uses of steroids is like dexamethasone is recommended 0.6 milligram per kg in 4 divided doses, commenced shortly before or simultaneously with antibiotics, and should be continued for 4 days in patients with strep pneumoniae, bacterial meningitis. But in spite of these strong recommendations, it is seen only 20% of the patients receive steroids. In patients of spinal cord injury, there were 2 randomized blinded control trials, the NARCISS-2 and NARCISS-3, which established the role of steroids in spinal cord injury. 30 milligram per kg bolus dose of methylprednisolone, which in a 60 kg man roughly comes out to be 2 grams, given to be in 1 hour, and then a continuous infusion of 5.4 milligram per kg per hour for next 23 hours. So it is, you can remember it that 2 grams bolus in 1 hour and 2 grams for 8 hours, repeatedly for the next 23 hours. And the Cochrane review in 2012 said that it is the only pharmacological therapy which has efficacy in phase 3 randomized trials. But still, the practice was not established. So multinational international body was formulated to re-look at the evidence and solve the controversy. And they also suggested that a 24-hour infusion of methylprednisolone should be offered to patients who come within 8 hours of acute non-penetrating spinal cord injury and not giving it to patients who come later. The major drawback of giving this high dose steroids is because these patients are spinal cord injury, they might have they are ventilated, this basal atelectasis, the risk of pneumonia becomes very high. So despite these international guidelines, there is no improvement in the motor score or the ASIA score at short-term or long-term follow-up. There are significant concerns about the harmful effects, especially pneumonia has been reported at very high rates in patients who receive this. And many patients with spinal cord injury have concurrent traumatic brain injury where steroids are contraindicated. So even in our clinical practice, I think it is purely based on physician choice because there is no long-term benefit or short-term benefit even in the motor score. We've seen patients, both type of clinicians, some prefer to use and others are actually not following this practice. Coming to conditions where intracranial pressure is raised because of trauma and spontaneous ICH, steroids are harmful. But if it is vasogenic edema, like in case of intracerebral tumors or brain abscesses, steroids are helpful in decreasing the edema and decreasing the intracranial pressure. But with the drawback that steroids might also reduce the antimicrobial penetration into the abscess. Traumatic brain injury, as I've just recommended, corticosteroid administration is not recommended, neither in patients of Guillain-Barré syndrome. Yes, suppression of immune response with glucocorticoid therapy is a vital tenet in the management of many anti-inflammatory diseases or rejection of transplanted organs in critical care situations. Steroids are a part of suppressing the harmful inflammatory response to brainstem death. Methylprednisolone, maximum up to 1 gram, is recommended to optimizing the bundle to improve vitality of donor organs. And a clinical condition like hemophagocytic lymphocytosis, which is a hyperferritinemic, hyperinflammatory response syndrome to infections, malignancies triggered by anti-inflammatory or autoimmune disorders. The steroids are first-line treatment. High-dose methylprednisolone forms the initial approach. So because of the paucity of time, I cannot further elaborate on these. So in summary, I would like to say that steroids have a proven role in conditions like anaphylaxis, airway edema, respiratory problems like asthma and COPD, severe PCP pneumonia, bacterial meningitis, tumor-related cerebral edema, organ transplants, hypothalamic pituitary axis insufficiency. They are certainly contraindicated in traumatic brain injury and late ARDS, but their role is accepted but controversial in septic shock, in early ARDS, in spinal cord injury, and in severe community-acquired pneumonia. Thank you. And I would like to invite you all to the National Conference of Indian Society of Critical Care Medicine, Criticare 2025, happening in Kochi from 5th to 9th of March 2025. Thank you so much.
Thank you, Dr. Kunjan, for comprehensively covering the topic and presenting in such a balanced manner for the use of steroid. Because as a critical care specialist or people who are working dealing with these patients, it is always a challenge that whether to use or not to use. So wonderful presentation. Before I say the topic is open for discussion from the questions from the audience, I would like to ask one question from you.
Yes.
What about like in the community acquired pneumonia? Is there any role of the biomarkers which can guide us that which patient will be benefited with the steroid and who will not be benefited with the steroids?
Bacterial pneumonitis. Actually, sir, they have been, most of the studies have included severe patients who require ICU stay, mechanical ventilation. And what I understand from all this, that patients who require intensive care with severe bacterial pneumonitis, it may be the septic shock part only, which is improving with this. As it is, otherwise in sepsis, clinician is very skeptical to use steroids. In viral, I understand, but in bacterial meningitis, we have bacterial pneumonitis, there are contrasting. So maybe biomarkers help in understanding us in the severity of the pneumonia, and maybe in those cases, if we are really sure that it is highly severe, the markers are very high, it might be helpful to use steroids.
Yeah, that is true. Actually, the recent interest has developed that to see the biomarkers. So probably in 2024, a study was published with a not very high number of patients, but they have really given us an insight to think of. They had taken a CRP as a marker, and what they had concluded in these around 169 or 170 patients, that if the this CRP value is above 150, those patients have a better improvement in the hypoxemia. They responded very well to use of steroid. However, the other category of the patient, they did not respond so well. So as you rightly said, that it's a severity possibly which is guiding us to use the steroid, and that improve the hypoxemia. Very rightly. So the house is open for the questions.
But the clinician is very skeptical in such, if we have bacterial sepsis, to know it is very difficult to take this decision to use steroids.
Very true. Very rightly said. So any other question from the audience, Dr. Chingan?
Congrats, Dr. Gunjan, to give us a lovely presentation on steroids. So there is no question from me, but I would invite the forum for any discussion.
I don't think, sir, there are any more questions. Ma'am has already covered the topic so nicely. I think I think now we can proceed further. Thank you, Dr. Vivek, sir, Dr. Jingan, sir. Thank you, Dr. Kunjan, ma'am. Anmol, please carry on with the others.
Thank you very
Thank you.
much for inviting us, and thank you.
We humbly thank all faculty and chairpersons for enlightening us this evening. Now we'll proceed. I'd like to request Dr. Jyoti Sharma, ma'am, faculty in Department of Anesthesia and Critical Care in AIIMS Bathinda, Punjab, to say a few words. She's also the organizing co-chair and also the workshop chair at RSACP Con 2025. Thank you, ma'am. Please.
Good evening, everyone. So myself, Dr. Jyoti Sharma, on behalf of Department of Anesthesia, AIIMS Bathinda, and RSACP Bathinda branch, I invite you all to the upcoming RSACP Con 2025, that is from 28th to 30th March. So we have an elaborate and elaborate scientific program from 28th to 29th March. And on 30th, that is the Sunday, we have 12 workshops. It will be a great academic feast, and we want all of you to join us in the program. So I welcome you all on from 28th to 30th March at Bathinda for RSCCP Con 2025.
Thank you so much, ma'am. Thank you for your invitation. We'll proceed, and the next session will be chaired by Dr. Kapil Singhal, sir, who is the Director and Head of Anesthesia and Critical Care, Metro Hospital and Heart Institute, Noida, and Dr. Priyamvada Gupta, madam, who is the Professor and at Department of Anesthesia and Critical Care, MGM College, Jaipur. And this session will be for environmental sustainability in intensive care, taken up by Dr. Shruti Sharma, ma'am, who is an associate professor in critical care in DMC Hospital, Ludhiana. Thank you, ma'am. We welcome you all.
Good evening to all. Are my slides visible?
Yes, ma'am. It is visible.
So thank you, the organizers, for giving me this opportunity on speaking such a little out of the box topic, as well as I'm happy and honored to be sharing this forum with my seniors, mentors, and stalwarts from anesthesia and critical care. I'm glad that I am able to speak on this topic in this forum. So I'll be speaking on the emerging concept of green ICU, or we can say it is a greater environmental sustainability in ICU as well as in anesthesia. So this is a very upcoming topic in the recent few years. So I would like to throw some light on this. Greenhouse effect and global warming, we have all read in our kindergarten, or you can say school years, that there are certain greenhouse gases that are detrimental to our environment, including carbon dioxide, methane, nitrous oxide, water vapor, as well as synthetic fluorinated gases. So we have learned in our earlier years that global warming causes a lot of global climatic changes, which we are now facing. Extremes of temperature, climatic effects, health effects of air pollution and climate pollution. So this is very detrimental. So proposed this all is measured in the proportion of the carbon dioxide levels in the atmosphere. So proposed threshold of carbon dioxide was for a healthy living is 350 parts per million, but currently it is 421 parts per million. So we have already crossed the threshold of 350 a long time back. So we have to do our bit in environmental sustainability. We have to, being a member of a global healthcare sector, we have to take certain measures. So we'll be speaking basically on that. If you go through this graph, we can see that at present we are here at where the red mark is there. So if the carbon dioxide emissions from the human consumption continue to increase exponentially, then life may not be possible in the future years. So we have to take stringent measures to curb the production of the carbon dioxide emissions on, and every industry, every person has to contribute to this. So that is where healthcare sector comes into picture.
So greenhouse gas emission, India is at number 3 globally, just behind China and United States. So how does global healthcare sector cause carbon dioxide emissions and increase the carbon footprint? So it contributes to 4 to 5% of the GHG emissions. This is similar to, you can say, to the participation done by the aviation. So carbon footprint from healthcare sector comes from the use of pharmaceuticals, industry, manufacturing of equipment, then delivery of the healthcare services and healthcare processes, ICUs, OTs, and all the consumption. And this all results in a carbon footprint. But we are excused generally because we say that we are doing it in the benefit of the patient care. But still, we want to give benefit to the patient, but still there are certain measures that can be taken on our part that can result in decrease in carbon dioxide emission from healthcare sector. So we'll be learning what we can do. So critical care areas or ICUs are the carbon hotspot of any hospital or healthcare center because of the resources used, equipment used, staff activity, high-end machines are being used, monitors are there. Similarly, anesthesia and OT contribute by the processes by the use of various equipments, general anesthesia, use of heating, humidification, and ACs. Light energy is needed as well as volatile anesthetic agents. These all contribute to carbon dioxide emissions and perioperative activities. These all contribute to the increase in carbon footprint from the healthcare sector. So before trying to culminate the effect of the healthcare carbon footprint, we must know that how to analyze the effect of the how much carbon dioxide certain process can generate. For that, we have two methods. One is life cycle assessment method or is material flow analysis method. Life cycle assessment method in this, what they do is they do a cradle to grave analysis of either a product or a process from its inception through a disposal. For example, they have studied that life cycle assessment study of morphine from an opium plant to a packaged product, that is 100 mg of morphine, produces 204 carbon dioxide emission corresponding to driving a car for 1 kilometer. Similarly, in the West, they have been doing studies and they are trying to find out that which processes have less carbon dioxide emissions and which processes have more carbon dioxide emissions. Similarly, material flow analysis is done. In this, what they do is all the material that goes into the system is studied throughout the process till the end, where the end product is formed, either a waste disposal or a sewage. And while studying these processes, they try to find out the carbon hotspots. For example, in a study conducted in ICUs in Australia and United States, they found that heating, ventilation, and air conditioning had the most of the carbon dioxide emissions. Similarly, in a Dutch study, they found that there were 5 hotspots in the institute, that is non-sterile gloves, bed liners, syringes, isolation gowns, etc. So this is how we can analyze our processes and decrease their use so that there is less carbon footprint. What are the principles in implementation of the sustainable practices? The principles are known as 5R concept or 10R concept. This is also understood as 4P concept. But we must remember that whatever concept we may undertake, but our target will be always to prioritize patient care without compromising the environmental initiatives. If we go through the 5R concept, this is refuse, reduce, reuse, repurpose, and recycle. And if we go by the 10R concept, it is refuse, rethink, and reduce before the product is consumed. And when the product is already in the process of consumption, we can reuse, repair, refurbish, or remanufacture or repurpose the product. And when the product is at the end of its life, we can recycle and recover. So they have said that these are the processes by which we can increase the life of the product, similarly decreasing the waste as well as the carbon dioxide emission. So the most emphatic of this is refuse. By this concept, we mean that whenever the care is not needed, whenever a process is not needed, we need not instill it to every patient. As is said in less is more. For example, during ICU, and there are many patients who are at end of life, or where there certain processes, certain procedures are not needed, but still we keep on doing the same procedure to everyone, like putting a center line or giving CRRT to patients who we may know that is on inotropic support, is not going to recover. So we have to choose our patient wisely, and benefit of health should be given to those patients only where it may be of benefit to the to prolongation of life of the patient. So less is more. Second, they have said is it is limit low value care or harmful care. Limit low value care is that care which provides minimal to no benefit in terms of patient care and health outcomes, and may even cause net harm. So there is no deficit to health from its omission. That is similar to the above concept of less is more. That is, the low value care should not be instilled to each and every patient. That is why scientists are saying that we should move from protocolized care to individualized care, that each and every patient should be analyzed, that certain procedure is needed in this patient or not, and if it is there is futility of care, there is no benefit going to happen to the patient, we must rethink our decision. So the concept in the end says that promote high value healthcare or low carbon healthcare. So as they have said that 10% of the care at present is low value care and 30% is harmful care. So in second component of the concept is reduce. As they say, prevention is better than cure. So reduce the use of antibiotics by antibiotic stewardship, decrease ICU stays, decrease ICU admissions, avoid MRI, CTs in each and every patient's. Use of reduce energy consumption, use LED lighting and high efficiency HVAC systems, transition from fossil fuels to fully renewable or natural energy sources such as solar energy. Digitization of the ICU will definitely help decrease the carbon footprint, and manage the supply chain to reduce medical waste. And oxygen stewardship is also very important. These are the processes. If we reduce their usage, definitely it is going to help in environmental sustainability. Then is reuse. There has been a long debate between that should we use reusable items or not, because West has largely converted into single use or disposable items. For example, their laryngoscope, bronchoscope, they are also disposable and single use, and they say that they are doing it in the interest of the patient care. But in our country, or you can say developing countries, we have a reuse policy. There are certain items that we that are single use, and there are certain items such as flexible bronchoscopes, supraglottic airway devices, laryngoscopes. We are still re-sterilization, cleaning, sterilization, and reuse is done. So we are in a way preserving the environment in that way. So we have to procure equipment in such a way that it can be reused in wisely. Recycle is also a fourth component of the principle, but recycling has the lowest impact, because for recycling also we have to have an industry and manufacturing unit. For recycling, we need personnel to operate recycling material, so it has the lowest impact. Then is repurpose or repair. So these are all concepts of 5R. Another components that can be added to this 5R concept is rethink. We have to review in the new light of green ICU or green environmental sustainability. We have to review our ICU processes, policies to minimize waste and increase recycling. We have to have stringent infection control policies, antimicrobial stewardship, telemedicine for ICUs, and going green for education and training. As we are now talking on an online forum, this definitely helps in greater environmental sustainability, because we are not having a physical meeting, and increased usage of resources. So reporting and research, and the literature says that now in this era, we should do our research on trials should be done on the basis of that what products have greater environmental sustainability, what products have less carbon dioxide emission. So these things should be kept in mind that now when we are planning our researches. Similarly, raising awareness and being a role model is also very important. And this requires collective effort from all the healthcare providers, patients, policymakers, all stakeholders. Just a minute.
Any problem?
Trying to get the screen back.
Screen is visible, ma'am.
It's visible to you?
Yes, ma'am.
Expand.
You can reshare, ma'am.
It's not the button. Is it visible now? Yes.
Yes, ma'am. Yes, it's visible.
So we have to, collective effort should be done from healthcare provider, patients, policymaker, and administrative willpower is also needed. So in the West, they are formulating green teams. So green team is a diverse team represented by nurses, doctors, pharmacists, together with expertise from infection prevention, engineering, purchase. Everybody is needed in this, leadership from the administration. So what the green teams do, they do rounds from in ICUs, OTs, all the healthcare industry and healthcare center, and they look for the processes where the stringent measures can be applied so that the emissions can be decreased. Now I'm not able to move my slide. Is it? Yes. So green teams, for example, in New Zealand, 65% of ICUs and 40% in Australia have dedicated clinicians or teams for green initiatives. So the green teams form a liaison between the healthcare workers and administration, and they also keep on do the rounds and identify green team or champions. Similarly, as we do infection control rounds, like similarly they do green team rounds and they continue their processes. So basically, our aim in all the endeavor is to move from linear to circular economy. In initial times, it was that material is brought to the hospital, then it is consumed by patient, goes in the system and goes to the waste. But now we are going to reuse, repair, refurbish, remanufacture, repurpose that material so that it remains longer in the system. So we are trying to move from linear to circular economy, so that there is minimal waste and water pollution, air pollution or wastage, and products are remain in the system for a longer period of time. So a little bit about anesthetic processes and OT processes. Apart from the earlier points that are mentioned, anesthetic gases have a global warming potential. So what is global warming potential? Is a measure of amount of heat trapped by an agent compared to carbon dioxide. So we have come to know that volatile anesthetic agents are halogenated fluorocarbons are potent greenhouse gas emitters. The GWP20 of desflurane is much, much higher than isoflurane and sevoflurane. And you can see in the table on the right side that as compared to desflurane, sevoflurane and isoflurane have much, much less global warming potential. So thus we can, titrate the use of the inhalational anesthetic agent in our OTs so that there is less carbon footprint from these gases. Also, less than 5% of the volatile anesthetic agents get metabolized in the body. The major 95% of it is emitted unchanged into the atmosphere. So that is why they remain in the atmosphere for a long period of time, contributing to the greenhouse gas effect. Also, atmospheric lifetime of these gases is very, very high. For example, atmospheric lifetime of nitrous oxide is about 114 years. And you can see in the table that chlorofluorocarbons have 50 to 100 years in carbon dioxide. Then out of the halogenated anesthetic gases, desflurane has the highest lifetime than the other halothane, isoflurane, and sevoflurane. So these points should be kept in mind while using our anesthetic gases in the operation theater. And ultimately, it penetrates the atmosphere, stratosphere, and causes depletion of ozone layer. So how can we practice green anesthesia? There is a silver lining in the dark cloud, that we have the help of TIVA, that is total intravenous anesthesia. Then we have low flow anesthesia. We can opt for regional anesthesia wherever it is applicable. Then scavenging system in the operation theaters are really helpful because they scavenge the waste volatile anesthetic agents, and they can help in producing medical grade anesthetic agents after cleaning, and it can be reused. Also, adopting neurotechnologies and digitization also in the operation theaters and anesthesia will help in decreasing the carbon footprint. Reducing the plastic waste, disposables, and promoting the use of the reusable devices whenever possible also will definitely help in the long way. But concern with TIVA is a green anesthetic method, but concern with TIVA is that there is wastage and pollution because of the plastic use as well as the intravenous tubing extensions. Also, they have said that 45% of the anesthetic drug waste is because of propofol only. The leftover propofol is discarded as such into the water body, and it improper disposable result in the harm to the aquatic animals and flora and fauna. So they have suggested that incineration at the 1000 degree for 2 seconds for disposal of propofol should be done to protect the environment. So still, TIVA also causes a carbon footprint, but in a study they found that carbon footprint of TIVA vis-a-vis inhalation and anesthetic agent, still TIVA produces less carbon footprint. So wherever the choice is available, we can use total intravenous anesthesia instead of inhalation anesthesia. Similarly, other measures that can be done is limiting the use of agents, nitrous oxide and volatile anesthetic agents that have higher global warming potential. Low flow anesthesia, already we have brought that point into notice. Then modern anesthesia workstation are very up to date and they use closed circuit and there is minimal wastage. Then end-tidal concentration control software, which can measure the amount of the volatile anesthetic agent, oxygen, carbon dioxide in the end-tidal air from the patient, and thus adjust the fresh gas flow rate. So that could be very helpful, as well as scavenging system in the operation theaters. So by this way, wastage can be decreased and environmental sustainability can be promoted in anesthesia. There has been a disposable or reusable device debate for a long time, because whenever we use a disposable device, we say it is in the interest of patient safety. And when we are saying about a reusable devices, we say that it is in interest of environmental safety. But to balance out this, the best solution would be that reuse the devices belonging to non-critical and semi-critical categories as per the Spalding classification. So how to do it? So what we can do is get our own house in order. Let's start from minimalistic things. Let's go to the basics, go for the low hanging fruit, as they say. Switch off the lights, reduce water wastage, reduce heating and AC consumption. When the OTs or when the ICU or bed is not in use, we shouldn't use lighting, and dim lighting, LED lighting should be used. Renewable energy resources should be used. Decrease the use of plastic, especially single-use plastic. And the use of telemedicine, promotion of online meetings, streaming conferences will be really helpful. If we are going for more impactful changes, we can consider limiting low value care, increase implementation of less is more interventions, moving away from protocolized care to tailored approach from or at individual basis, avoid unnecessary or futile ICU admissions, and use the principle of palliative care where the end of life care is there or where patient is terminal or futility of care is there. We should practice the principle of palliative care. Then we have already earlier discussed about 5R or 10R concept that can be inculcated in our practices. Then use of volatile anesthetic agents having low GWP20 values. Life cycle assessment of the products and processes should be done. And those processes should be chosen which has a decreased energy use or decreased carbon footprint. And green champions, clinical champions, multidisciplinary green teams are the need of the hour. If I want to discuss how they have done in the West, there is a study from Netherlands that from hotspot to action. So they did the material flow analysis of their practices, and they found that gloves, gowns, CRRT bags are being used inadvertently a lot. So for gloves, they did a hotspot analysis, and they found that 108 gloves per day per patient are being used. So the equivalent to the carbon footprint of 9.3 kg carbon dioxide emissions per day. So they applied our approach. In our approach, they applied the principle of refuse and reduce. And this resulted in a largest impact. Then also they redesigned their dispensers so that when they're pulling out one or two gloves, multiple bunch of gloves should not come out and increase the wastage. Also, they color coded the dispensers. So if you want a 7 number glove, only 7 number color you will approach that dispenser only. If you want a 8-number glove, you will approach that dispenser only. So with this method, they reduce the wastage. Similarly, they applied this principle to gowns also. They found that 16 single-use gowns per ICU patient per day are being used, because in the West, they are still in the single-use gown they use for each and every patient. So they applied our approach, and they applied the concept of refuse and reduce, and they transitioned from single-use gown to washable or wearing aprons when working with a non-isolation critical patients. Similarly, they applied this concept to CRRT bags and their packaging, and they used the concept of recycling and redesigning CRRT bags in a more environment-friendly way. So this is how they are analyzing their processes, and they are trying to reduce the carbon footprint of their processes and systems. So at part of India, what India has a commitment. So India signed a treaty called as the Conference of Party COP26 with the United Nations, and they said that 5 nectar elements of India's climate action, that is called as Panchamrit action. So India has committed to reach the 500 gigawatt non-fossil energy capacity by 2030. 50% of its energy requirements from renewable energy resources by 2030, reduction of total projected carbon emissions by 1 billion tons from now to 2030, and reduction of carbon intensity of economy by 45% by 2030 over 2005 levels, and achieving the target of net zero emission by 2070. So with this commitment, India is certainly taking some steps to decrease the carbon emission, and we also from global healthcare sector have to contribute to it. So what can we do in our ICUs? As already said, summarizing the earlier PPT, that is considering less can be more, avoid the usage, reduce, reuse, recycle, daily rounds should be done, and consider ethics and futility of care in patients, life cycle assessment of processes should be done, reduction of energy use, and green teams can be the champions. Similarly, in green OTs for green anesthesia, volatile anesthetics having low global warming potential should be used. 5-hour or 10-hour concept can be applied. TIVA or regional anesthesia or radiate the silver lining, and optimal use of heating, ventilation, and ACs can be used. And it also needs an administrative political will, collaborating with the artificial intelligence, engineering departments, all the stakeholders. It also needs intersectoral collaboration, and also dissemination of education, information. This all will go a long way to save our Earth and make it a green planet again, and have an environmental sustainability for a better future for our next future generations. Thank you very much for your patient listening.
Ma'am, over to the chairpersons, Dr. Kapil Singhal sir and Dr. Priya Boda, ma'am.
I must congratulate, first of all, Dr. Shruti for covering this topic so nicely. And I think you have not left any stone unturned as far as environment sustainability is concerned, and role of anesthesiologists or intensivists. You have covered both anesthesia as well as ICU care, but
Thank you so much.
very well covered. I must congratulate you. You have covered everything. But yes, I would like to say a few things that it's easier said and done, because there is a constant conflict going on between consumer and market forces versus clinician and medical personnel. As you said, Western world, they are making green teams or something like that. On one hand, they are encouraging more and more use of disposable items, including scopes, laryngoscopes, scopes, everything. And on the other hand, they are making green teams. I don't know what is the relationship between the two
There is
things.
a lot of dilemma there. Actually,
Yes.
I was at a conference last year at Singapore. So they were showing me flexible bronchoscopes, single use, disposable. So I
Yes.
was surprised that why to use this in a one patient and dispose it of such a high-tech equipment like.
No, not only bronchoscope, they are
Yeah.
using disposable laparoscopic instruments for surgeries. They just throw it off. So, but nothing more to say from my side. Again, big congratulations, and understanding the importance of environment sustainability and the role of anesthesiologists or intensivists. We, anesthesiologists, ISA Noida branch, we have already launched a campaign on our website, Safe
Okay.
Environment campaign. It was launched last year, and any of you can put your comments or can join that on ISA Noida website. So thank you so much, Dr. Shruti. But
Thank you.
we can take any comments from audiences or questions.
It was a very nicely covered topic. It was really an eye opener. So I think it is time to rethink. We should change our habits because if we have to persist, we have to protect our environment. Otherwise, it will be a threat to the human race, as we already know. We
Yes,
already
ma'am.
talked. The environmentalists all always talk, but we as doctors, we as intensivists and anesthetists also we can help in protecting our environment. Because like in olden days, we were using, even today also we are using, in India we are mostly using gowns which are made of cotton material that we are autoclaving. So that is a good practice that we should encourage. And instruments also, we are mostly reusing the instruments. We are autoclaving or ETO, whatever material methods we have. So I think we should rethink and change our habits and style of working. So it was a really eye opener that we can minimize use of nitrous, we can minimize use of inhalational, and we can choose better agents. So if everybody gives a little bit uh, input and help, then we'll at least have some impact on protecting our environment. That was a really nice talk, ma'am.
Thank you, ma'am.
Yeah.
Thank you so much. I would like to thank all the chairpersons and the faculty who enlightened us with their detailed topics. And now we'll also take the lead from ANZICS, the New Zealand Society of Critical Care, who have already mentioned that their first initiative was to clean up their tea rooms. So they started green tea rooms. And then they also say we should reduce disposables, start at our own homes. And of course, we dream big and we act small. And with little steps, we'll win. Thank you all. I'd like to invite Dr. Tanveer Singh, sir, for concluding the session.
Thank you, Anmol. It was a really nice talk, Dr. Shruti ma'am. Actually, the concept of the green teams and this is actually we should start in our routines and we should proceed with this. And as my little daughter is very big supporter of this green initiative and of reduce, reuse, and recycle. She never allows a plastic, not even a single bag of plastic is allowed inside my house. That is a fact. She does not even, whenever she goes to the grocery, even she does not do that. So yes, as we ma'am said, Priyamoda ma'am said that we can start from little bit, and this is how we can go ahead. Sincere thanks to Dr. Naveen Malhotra sir, President RSACP, who gave us this opportunity to conduct this webinar on this topic, which is being less discussed in our country. Sir, your final words, and then we will go ahead. Then we'll conclude.
My final expressions will be that thank you to both the speakers and all the chairpersons, Dr. Kapil, Dr. Premada, Madam, and Dr. Kunchan Paul. It was excellent and talking about the role of steroids and Dr. Yuki also. So we enjoyed interacting with you. And once again, a warm welcome to all of you to the forthcoming annual national conference of Research Society of Anesthesiology Clinical Pharmacology. And I'm saying with full conviction that you will enjoy the academic feast. Dr. Anju Grewal and her team are working since last more than 1 year for making it a good grand academic feast, and you will enjoy all the 12 workshops. I don't know in next week, she may add another workshop because of the increased demand. Recently, we added mechanical ventilation workshop. So, but yes, we have as a policymaker shifted all the workshops to Sundays, so that it is easy for the HODs as well as the postgraduates. HODs can give leave and PGs can get leave. So you can interact directly with the faculty, and there will be cutting edge discussions, pro-con debates, and there's a special slots for young speakers also. All of those who are interested in presenting your clinical work, feel proud in that. There's a session on 6-minute short. So you can tell the entire country about your experience of a particular clinical scenario in 6 minutes. And there are lots and lots and lots and lots of awards to be won. There are around 14 categories of award paper presentations, and in all the specialties of anesthesiology, with good financial remuneration also, in addition to the prize, medal, and the certificates. So welcome all of you to Batinda, and thank you team RSACP Punjab, Dr. Tanveer, Dr. Anmol has been a very, very good master of ceremony and nicely coordinating the webinar. And thank you, Dr. Anju Grewal and Dr. Jyoti and Dr. Shruti and Dr. Pal. Thank you very much.
Thank you,
Thank
sir.
you so
Thanks,
much.
ma'am.
So,
Thank you, Anju
Thank
ma'am.
you so much, sir.
Thank you. Thank you so much.
thank
Can
you.
I just
Thank-
appeal to all of you here? I see around 35 and 37, and I would like that all of you please register and encourage registrations. And this is something that we really need to bring to the forefront. I see a lot of us from Punjab, and together only we can ensure that, yes, Punjabis also do register for conferences and attend it academically well. Thank you all for your support. God bless you all.
Thank you, ma'am. Thank you.
Thank you.
Thank you, everyone.
Thank
So,
you, ma'am. Thank you.
Thank you.
When you are the host, you can close the meeting.
thank you.